Greetings, ladies and gentlemen. It is a great honor for me to participate in the IFNUS 2021 World Tour. I wish it could be in person, but we've got to do the best that we can. I am very thankful for this opportunity to Dr. Jay Shah and the organizing committee for inviting me to share some thoughts with you about the current status of selective and comprehensive neck dissections. What we hope to do this in this session is to first define some nomenclature, outline in general the indications and role of selective neck dissection and comprehensive neck dissections, discuss in detail the role of neck dissections as the management of squamous cell carcinoma of the upper aerodigestive tract. We will spend the majority of our time in this topic. And then we will briefly outline the role of these neck dissections and other neoplasms of the head and neck. With regards to nomenclature of the lymph nodes, we all know about the lymph node groups, and this is very well established now. But what I wanted to mention is that this is not just a clinical determination anymore. There have been very detailed landmarks established radiographically, as you can see here. And I recommend to all of you to review this paper by my friend Vincent Gregoire, which outlines all those radiological landmarks or limits of the different levels in the neck. With regards to nomenclature of neck dissections, we have seen from even before 2001 classifications adopted by the American Academy of Head and Neck Surgery and the American Head and Neck Society of the different neck dissections. A few years back, a group of Ferlito, Jay Shah, Robbins, and myself proposed this classification in which the neck dissection is designated as such, and we designate the levels that are removed and the structures that are non-lymphatic that are removed. What I would like to use today is what I call a practical classification that divides the neck dissections in comprehensive, selective, and extended. But we will use the designations recommended in these classifications, i.e. the lymph nodes groups that are removed and the structures that are removed. So let's briefly mention in general the indications and role of selective versus comprehensive neck dissection. The selective neck dissections are chosen mainly based on the location of the primary tumor, and also in terms of the stage of the neck, early stage, N0 or N1. And the role of these operations can be therapeutic by itself. In other words, the neck dissection alone can cure the patient. But in the majority of cases, they have a staging role. The comprehensive neck dissections are dictated primarily by the extent of the neck disease. And in terms of the role, they also have a therapeutic role, but they cannot be therapeutic in the majority of cases by themselves. But they do it in combination with either chemo and radiation alone or in combination. And as we will see in a minute, these comprehensive neck dissections also have a staging role. So with that in mind, let's look at the different selective neck dissections. The selective neck dissection 1, 2, 3, and 4, or 4, the all supraomohyoid neck dissection, is used in the surgical treatment of squamous cell carcinomas of the oral cavity. When you've decided to treat a squamous cell carcinoma of the oral cavity primarily with surgery, and you need to do a neck dissection, this is the operation to do. So the question when you're faced with this situation, like in this patient with a clinical N0 neck, is when does the neck need to be treated? And for For many years, we have adhered to this threshold of probability of lymph node metastases of 15 to 20%. So with that in mind, then, if we look at the oral cavity, these tumors here will not be treated with surgery alone in the majority of cases. They will be treated with surgery and radiation or chemo. So let's look at those that can be treated with surgery alone. And of those, T1, T2, the majority of patients are above that threshold of 15 to 20%, except perhaps the buccal mucosa here. But, so that's the likelihood of lymph node metastases in oral cavity. Also, a determinant or a factor to take into account when deciding when the neck needs to be treated is the thickness of the primary tumor. And for many years now, we've known that 4 millimeters is the threshold that most of us use, above which the rate of lymph node metastases is high enough to warrant an elective neck dissection. What about the selective neck dissection 2 to 4? The previously known as lateral neck dissection is used in the surgical treatment of squamous cell carcinoma of the larynx and pharynx. And this is the operation depicted here in this picture. The role of this selective neck dissection in the management of cancer of the larynx and pharynx is threefold. It's used with patients treated primarily with surgery. It's used when patients are treated with organ preservation regimens. And third, is used in patients undergoing salvage laryngectomy. So in patients primarily treated surgical, once again, we look at the likelihood of subclinical metastases. For the larynx, we see that only the most advanced glottic cancers are above this threshold of 20%, but all supraglottic tumors of any stage are above the threshold, the same as the hypopharynx. So the treatment will be the neck will be electively treated in all of these patients. What about the oropharynx? We see the same thing here. Basically for tonsil, base of the tongue, and the oropharynx in general, any stage is above that threshold and needs elective treatment of the neck. What's the role of neck dissection and when we use organ preservation regimens? It's used for the management of residual disease in the neck after treatment with radiation plus minus chemotherapy, such as a patient like this. A PET scan 12 weeks after finishing treatment shows this. There, a selective neck dissection can be done safely. Our recurrence rate in 50 operations was 4%. Others have reported 3 and 2%. So it's a very reasonable recurrence rate. These operations are done through a simple transverse incision. And when we do these operations in this particular situation, we're always very careful at looking at the walls of the internal jugular vein, especially in proximity of the tumor. If you see this whitish discoloration, indicates that the tumor is too close, and we don't hesitate to remove a portion of the internal jugular vein as we have done here. This situation also brings up the issue of super selective neck dissection that Tom Robbins put forth. In other words, in these patients that have only one node positive after treatment, can we do just a dissection of level 2 or perhaps level 2 and 3? Robbins reported 57 operations in which he found nodes beyond that single node in 3.7% of the patients. And we looked at 50 operations and we find a no tumor beyond that single node when it is in level 2. So this super selective neck dissection can be applicable to these patients that are treated for residual disease post-chemo radiation. What's the role of selective neck dissection in patients that undergo salvage laryngectomy? A few years ago, Alvaro Sanabria, as long as Jayton Shah, myself, and others did a systematic review of the literature on this subject. And this is what we found, that there are authors that favor elective neck dissection because the rate of occult metastases found varies between 12 and 24%, which is not a negligible rate. And also because the salvage rate of no metastases in the observed neck is only 21%. So only 1 out of 5 patients that you observe, they develop metastases are salvaged. Other authors favor observation, and the reason for that is that the 5-year survival is similar for patients that undergo neck dissection and those who are observed. In general, in our practice, we prefer to do an elective neck dissection in a salvage laryngectomy. However, I caution you that you need to use common sense. In this patient with a very supple neck after radiation, I wouldn't hesitate to do a selective neck dissection. However, in this patient with so much skin damage and fibrosis in the neck, I don't think any neck dissection in this patient would be prudent. Now, when doing the selective neck dissections, there are what I call sub-level issues. And the first one is level 2, to be or not to be. Do you dissect level 2B or not? Well, when we look at the prevalence of metastases, this is another systematic review of the literature that shows that in the oral cavity, metastases in sublevel 2B occur in 3.9% of the cases, mostly in cases with oral tongue cancer. In the oropharynx, a little higher, 5.2%, and in the larynx, very low. So you might use this to determine whether or not you want to dissect level 2, perhaps when you do surgery for oropharyngeal cancer. But finally, we have some data about the survival when you spare level 2B. And in this randomized study published a couple of years ago, the disease-free survival at 36 months was the same, statistically the same, no difference between those cases in which the level 2B was spared and those that were dissected. And also, they provide data about function of the spinal accessory nerve at 1 month. In the dissected group, 95% have signs of denervation, while only 45% in the spared group. Fortunately, at 1 year, most of that gets corrected, although 5% of these patients still do have some denervation patterns. What about level 4? Is the routine inclusion of it justified? And in the larynx, we have several papers that have been reported. The positive notes found in level 4 in the absence of palpable metastases elsewhere vary between 0 and 2.3%. So I think it's safe to say that in the N0 larynx cancer, there is really no need to routinely remove level 4. What about the oral cavity? The controversy there started years ago when my dear former mentor, Robert Byers, published that in cancer of the tongue, he found 15.8% of the cases with skip metastases in level 3 or 4. And other authors like Green and Luzinis have reported similar rates of metastases to level 4. However, others like our group with Kafif et al., Shah and Memorial and others have reported that the rate of metastases is relatively low, 1.8% to 3.2%. So what do I make out of this literature and how do we deal with this in our practice? We dissect level 4 only when we find a suspicious node in level 3 or when there are multiple nodes in levels 1 and 2. Okay. What about the efficacy of selective neck dissections? Well, let's look at this situation first. Clinically N0, pathologically N0 neck. And we have several publications that have addressed this. I have chosen these 3 here in different years. They report recurrence rates in without differentiating those patients that were treated with surgery alone or with postoperative radiation therapy, and the recurrence rates varied from 4.9 to 8.8%, relatively low. But these other papers, these two in particular, tell the story that when you face this situation of a pathologically N0 neck, surgery alone and surgery and postoperative radiation therapy do about the same. In other words, the addition of postoperative radiation therapy in these cases does not add much to their benefit. So, but in general, the recurrence rate when the clinically N0 neck is found to be pathologically N0 is around 4.3%. And radiation therapy is not beneficial in those cases. When you compare the selective versus the comprehensive neck dissection in oral cavity cancer treated with selective neck dissection in a pathologically N-positive neck, the control in the neck is statistically the same. And the survival in this prospective study of the Brazilian head neck study group published many years ago is equally not different statistically. So in summary here, if we have a clinical N0 neck, and you do a selective neck dissection and it's pathologically N0, then no further treatment is necessary. That is the therapeutic role of the selective neck dissection. Well, what about when we do a selective neck dissection and the pathology reveals metastases in one node, in one neck? These two studies are very interesting because they show in a fairly good number of patients that the addition of radiation therapy in this situation gives a much better result in terms of recurrence in the neck than when surgery alone with no radiation is utilized. However, when Rodrigo et al. And several others did a systematic review of the literature not too long ago in 207 patients, yes, the rate is of recurrence in the neck with radiation is more than half less than the rate of recurrence when no radiation is utilized in this situation. But this difference was not statistically significant. So the question of whether or not to radiate the pathologically in one neck is still out there, not completely resolved. So in this situation then, shall we use postoperative radiation therapy? Most likely yes, particularly when there is a node with extracapsular spread or when there is a node that's positive beyond the first echelon of lymphatic drainage. And this is where the staging role of a selective neck dissection begins. What about the efficacy of selective neck dissection in the clinically N-positive neck? And the first question is, when do you use a selective neck dissection in a clinically positive neck? Well, when there are clinical radiologically lymph node metastases like you see in these patients here. When the metastases are limited to level 1 or 2, this is not a hard and fast rule. Less than 3 centimeters. Sometimes we've operated somebody with a 3.5 centimeters, but around that size. We do not, or in general, selective neck dissection is not recommended in the clinically N-positive neck when there is fixation of the node, when there is involvement of extranodal structures, and when there are lymph nodes at multiple levels, perhaps with the exception of levels 1 and 2, and certainly when there are lymph nodes at level 5. What about the efficacy of it? And we look at pathologically N2 plus in this systematic review of the literature. Patients treated with radiation therapy postoperatively are 4 times less likely to recur in the neck than patients not treated with radiation therapy. Once again, this difference in this number of patients was not statistically significant, but it gives you the idea that there is a trend here. In these studies, there was no clear differentiation between those patients that had extracapsular spread and those that didn't, those that had nodal involvement and those that didn't. So take this with a grain of salt. It appears that in these cases, when there are multiple nodes or where there is extracapsular spread, radiation therapy may be more effective postoperatively. Comparing selective versus comprehensive neck dissection in the pathologically unpositive neck, this meta-analysis about 6 years ago shows that there is no statistically significant difference in the recurrence in the neck when these two types of neck dissection are used. So in summary of all of this, we'll see when the neck is clinically unpositive and we do a selective neck dissection. If there is multiple nodes, we use postoperative radiation. If there is extracapsular spread, as we will see in a minute, we prefer to use a combination of radiation and chemotherapy. Once again, the staging role of the selective neck dissection. Let's talk about now, about comprehensive neck dissections. The role of a comprehensive neck dissection is very simple, is to adequately remove all macroscopic tumor in the neck. Okay? So adequate removal of macroscopic tumor in the neck, when there are multiple matted nodes or multiple large nodes at different levels, as in this patient, then adequate removal of the disease requires a radical neck dissection, or a neck dissection 1 through 5, with removal of the sternocleidomastoid, the internal jugular, and the spinal accessory nerve. Adequate removal when there is an N-positive neck and the spinal accessory nerve can be preserved without creating a plane of dissection. Exactly in the same way as we deal with the facial nerve in parotid surgery, then adequate removal can preserve the spinal accessory nerve in a modified radical neck dissection, or levels 1 through 5, with removal of the sternocleidomastoid and the internal jugular vein only. When there are multiple nodes at different levels, including level 5, as in this patient, then adequate removal can be done with a neck dissection that preserves the internal jugular vein, the sternocleidomastoid muscle, and the spinal accessory nerve. Well, it is very well known now, since these two studies were done years ago by the RTOG and the EORTC, comparing postoperative radiation with postoperative radiation and chemotherapy, that postoperative radiation and chemotherapy yield better local regional control than radiation alone. And this was particularly the case when there was extracapsular spread and in the presence of positive margins. So, in summary, when we have either a clinical N0 or in positive neck, we do a selective neck dissection, and there are no pathologically demonstrable nodes, it's a PN0, no further treatment is necessary. If there is a one node positive, you may consider postoperative radiation. If there are multiple nodes positive, radiation, postoperative radiation. If there is extracapsular spread, the combination of radiation and chemo is more effective. When we do a comprehensive neck dissection for a clinically unpositive neck, we never do a comprehensive neck dissection anymore for a clinical N0 neck. So in these cases, once again, if there is only one node positive, which can occur rarely, postoperative radiation may or may not be utilized. But when there are more than one node positive or extracapsular spread, we recommend postoperative radiation and or chemotherapy. I hope all of this is clear. Now let's talk about briefly about the other about the role of these neck dissections, particularly the selective neck dissection, in other head and neck neoplasms. And I will do this briefly because I trust that My colleagues that have addressed these particular neoplasms have discussed this in a more nuanced way that I will. Well, first we have this selective neck dissection that removes levels 3 to 5, the postauricular and suboccipital lymph nodes. This is the old posterolateral neck dissection. It's currently indicated in the management of melanoma, Merkel cell carcinoma, squamous cell carcinoma, or any other cutaneous carcinoma with palpable lymph node metastases in the suboccipital region or in the posterior triangle of the neck. Case in point, melanoma here behind the line through the external auditory canal, another melanoma here in the midline with metastases here in level 5. The lymphatic drainage we know is to the retroauricular and suboccipital lymph nodes as well as to the posterior triangle of the neck. So in those cases, we do this type of dissection, preserving in this case and in many cases the spinal accessory nerve and the internal jugular vein. The selective neck dissection of level 6, which we know as the central compartment dissection in papillary and medullary thyroid cancer, as it is seen here. It can be done bilaterally. I will not dwell on the indications or role of it because I'm sure whoever talked about thyroid carcinoma addressed this in great detail. But this is the operation. Now, when there are metastases from papillary thyroid cancer to the lateral compartment of the neck, in the past, we routinely used a comprehensive neck dissection of levels 3 to 5. And that operation, like this, with preservation of the spinal accessory nerve, the sternocleidomastoid, and the internal jugular vein, could be done easily through an extension posteriorly of the thyroidectomy incision. However, in recent times, in the last couple of decades at least, and more and so more recently, there is a trend to use selective node dissections of levels 2, 3, and 4, and portions of level 5B when there are metastases of papillary thyroid cancer in the lateral compartment of the neck. Here we have such a patient, the central compartment dissected, and here's the selective neck dissection of levels 2, 3, and 4. And in these cases, notice that we go a little more behind the level of the cutaneous branches of the cervical plexus to remove as much as we can of level 5B. When we do this operation for palpable metastases with papillary thyroid cancer, we always dissect the level 2B because metastases there can occur in these patients. Finally, we have salivary gland carcinomas, and again, I trust that this has been addressed in detail, but suffice it to say that the selective neck dissection that is to be used if you want to treat a parotid carcinoma with an N0 neck. If you want to treat it surgically, then keep in mind that the metastases, the occult metastases in the neck occur in 90% of the cases in level 2 and 3. This is the type of dissection, the parotidectomy, and levels 2 and 3. Once again, in these cases with parotid carcinomas, we always dissect level 2B, at least for now. And then in the case of some mandibular carcinomas, if you elect to treat the neck surgically, as long with the primary, then remember that 100% of occult metastases occurs in level 1, 2, and 3. And this is the type of neck dissection that will be done for a submandibular gland carcinoma. So I hope that in the past 30 minutes or so, we have covered the objectives that we outlined at the beginning, clarifying the nomenclature, outlining in general the indications and the role of selective and comprehensive neck dissections. And I hope I've given you a clear idea of what the current role of these neck dissections is in the management of squamous cell carcinoma of the upper aerodigestive tract. And we have briefly discussed the role of these operations, particularly the selective neck dissections in other neoplasms of the head and neck. Thank you very much for your attention. And once again, thank you for the opportunity to share with you these thoughts at this wonderful opportunity of the World Tour 2021.